Welcome again to another talk in my series Surgery for Undergraduates. Today's topic is upper GI bleeding, which is a very important and common subject in surgery. Upper GI bleeding, or UGIB for short, is defined as the bleeding from any site along the gastrointestinal tract that is above the ligament of Treats. The ligament of Treats is the fibrous band that attaches the duodenojejunal junction to the posterior abdominal wall around the hiatus, diaphragmatic hiatus in the posterior abdominal wall. Here, this picture here shows you a clearer view of the ligament of Treats. Okay, ligament of Treats. And this is the second part of the duodenum, third part of the duodenum, fourth part, and as it becomes the jejunum, it is attached to the posterior abdominal wall. So bleeding from anywhere proximal to this ligament of Treats will be considered upper GI bleeding. And anything bleeding arises below this ligament of Treats is considered lower GI bleeding. Practically, the proximal or upper GI bleeding will be involve structures as the esophagus, the stomach, and the duodenum. So the bleeding from any of these sources or these sites will be considered upper GI bleeding. There are some definitions that must be made clear before we continue with the topic. Upper GI bleeding, as I've already explained, bleeding from the proximal to the ligament of Treats. Hematemesis is the vomiting of blood, which can be either fresh blood or altered coffee ground blood. Hematemesis is diagnostic of upper GI bleeding. Melena is the passage of tarry, black, or maroon stool, which can be either from the upper or the lower GI tract, and it is more often from the upper GI tract. Hematochezia is the passage of bright red blood per rectum, and it is usually characteristic of bleeding from the colon. Upper gastrointestinal bleeding from the esophagus, stomach, or duodenum, which is all proximal to the ligament of Treats, can present in a number of ways. First, symptoms of anemia, such as pallor, giddiness, or even fainting. Hematemesis, or vomiting of blood, or vomiting of coffee ground emesis, which is altered blood accumulated in the stomach. Melena, or the passage of tarry stools. Hematochezia, especially if the bleeding from the upper GI is massive, it can also present as hematochezia. It can also present as hypovolemia and shock, and non-specific complaints like dyspnea, abdominal cramps, chest pain, and fatigue. What are the causes of this bleeding? From the esophagus, it can be esophagitis, usually due to gastroesophageal reflux, or can be radiation esophagitis. It can be due to mallory-Weiss tear of the esophagus due to persistent vomiting. Esophageal varices is another common cause of bleeding from the esophagus. And lastly, CA esophagus. From the stomach, the most common is gastritis, the so-called erosive gastritis due to erosive food, alcohol, and drugs, especially non-steroidal anti-inflammatory agents. Prednisolone can even be due to aspirin and other anti-ischemic heart disease drugs, and also the use of anticoagulants. Gastric ulcer is another common cause of upper GI bleeding from the stomach. Carcinoma stomach and AV malformations in the wall of the stomach are another common cause of bleeding. From the duodenum, you have duodenitis, again, which can be due to drug-induced ulcer, duodenal ulcer, polyps in the duodenum, and dewlaphoid lesion in the stomach, and at times in the duodenum as well. In upper GI bleed, this slide shows the incidence of the various causes of the bleed. Duodenal ulcer 30%, gastric ulcer 20%, varices 30%, and gastritis and duodenitis another 5 to 10%. So together, ulcers form 50% of the incidence of bleeding. The others are due to varices and gastritis. The others listed here are rarer causes of bleeding GIT. Clinical features. Symptoms are usually hematemesis and melena. These are the two main symptoms of upper GI bleeding. Occasionally, they have pain in the epigastric region, and they may have the symptoms of the underlying disease that causes the bleeding, like chronic liver disease or cancer of the stomach. As for the signs, again, anemia is on pallor. This is the main symptom sign that you detect in these patients. They can have tenderness in the epigastrium, and on rectal examination, you may detect melena or fresh blood. They will have increased heart rate, decreased pulse volume, and a decreased BP. These three are the signs of hypovolemia due to excessive vomiting of blood. Next, investigations. The main investigations of upper GI bleed is OGDS, or esophagogastroduodenoscopy. Okay, this is a compulsory examination for all cases of upper GI bleeding, and this can be done as an emergency or as an elective case. Together with this, you can also test for H. pylori or a Clow test by taking samples of the tissues of the gastric mucosa, which tests for the urease test. It can also be biopsied to rule out malignancies of the stomach. OGDS has the advantage as it is not only diagnostic, it is also therapeutic. In bleeding ulcers, the ulcers can be injected or even cauterize the bleeding vessel to stop the bleeding. Management. First, resuscitation or the initial treatment consists mainly of IV fluids, colloids, crystalloids, and even group and cross-match blood for transfusion. At the same time, we give intravenous proton pump inhibitors, especially omeprazole, or my choice is esomeprazole, intravenously. And after this stabilizing the patient, you prepare the patient for OGDS as soon as possible. At times, if the bleeding does not stop, then emergency OGDS may have to be done. This is a general outline to the approach to patients with significant upper GI bleed. Okay, as I mentioned, aggressive fluid resuscitation, routine blood tests including group and cross-matching of blood, intensive monitoring in the ICU or HDU, blood transfusion if necessary, and upper endoscopy to evaluate and treat the cause of bleeding. The assessment of the severity of bleeding is very important in the management of a patient with upper gastrointestinal bleeding. The amount, in this respect, the history is of paramount importance. The amount of bleeding, the presence of clots, the frequency and the duration of bleeding is very important. So it's very important to get a detailed history of the hematemesis of the patient. The color of the blood that's vomited is also important. Arterial blood tend to be bright red in color as compared to venous blood. And arterial bleeding can be very, very rapid and cause the patient to collapse much earlier than venous bleeding. Clinically, giddiness and at times fainting are indicators of severe bleeding. Assessment of the severity of the pallor, the vital signs, and the pulse volume are important indicators of the severity of bleeding. These days, we have scoring systems to assess and grade the severity of bleeding. Two of the most commonly used grading systems are the Glasgow-Blatchford score and the Rockall score. Okay, these make use of the various clinical and laboratory parameters which are commonly used in the management of patients to give them a grade or score, so as which will determine the severity of the bleeding and the prognosis of the condition this patient is undergoing. Okay, this is the summary of the Glasgow-Blatchford score. Okay, here you see it makes use of the pressure, systolic blood pressure, the pulse rate, the presentation with melena, presentation with syncope, the presence of liver disease or cardiac failure. So these are all used to give a grading used in the grading system for the patient. Then they also make use of the renal function test, the hemoglobin, which also contributes to the severity or mortality prognosis of the patient. Okay, here you can see the same thing: systemic blood pressure, blood urea, hemoglobin, and other variables. So these are all the factors that are used to assess the severity of bleeding by grading them. And most patients need intervention, some form of intervention, if their score is 6 or higher. This is the other system which I mentioned, Rockall score. Also similarly, it also makes use of the presence of comorbidity, the age of the patient, the source of bleeding, the shock state of the patient, okay, and stigmata of recent bleeding. So these are the features. And it also uses the renal failure, liver disease, metastatic disease, and congestive heart failure. Again, these are all given points and a final score calculated. A score of less than 3 carries good prognosis. A score more than 8 carries a high risk of mortality. This is the treatment of peptic ulcer. I shall just briefly talk about peptic ulcer treatment because it is one of the most common causes of upper GI bleeding. It basically consists of medical treatment that consists of the triple regime: 2 antibiotics and 1 PPI. The antibiotics which I commonly use are clarithromycin, 500 milligrams BD, amoxicillin, 1 gram daily, and omeprazole, or I use esomeprazole, 40 milligrams BD. Okay, this is the triple regime. There are many variations of this triple regime. but this is a simple regime which I find high compliance among the patients. It's important for this regime to be used for at least 6 weeks or until the ulcer is healed. The PPI must be continued until the ulcer is totally healed, as ascertained by a repeat OGDS about 6 weeks later. I will touch briefly on the treatment of esophageal varices, another important cause of upper GI bleeding. Besides the acute phase of resuscitation, there's a role for the use of IV pitocin, which is a vasoconstrictor which reduces the blood supply to the varices at the lower end of the esophagus and the gastric fundus, thereby reducing the degree of bleeding. Another hormone that has been used commonly is somatostatin, which is produced by the pituitary as well as the pancreas. These two causes a marked reduction in the acid and reduces the bleeding from the varices. The analog is octreotide. We also use infusions of PPI, proton pump inhibitors, to reduce the acid from the stomach, thereby reducing the risk of stress ulceration and bleeding. To reduce the portal pressure is a long-term management of esophageal varices. To do this, it can be either done by medical means or by systemic surgical means. Medical is always the first choice, and it is using beta blockers. The most common among it is the use of propranolol, to be given to the patient orally for life. If this does not reduce the incidence of rebleeding, then consideration is given to a portosystemic or a portocaval shunt, the most common of which is the endoscopically done TIPS, transjugular intrahepatic portosystemic shunt. This diagram shows you the shunt between the portal vein and the systemic vein. So a prosthetic shunt is created endoscopically, and this will reduce the pressure from the portal veins, thereby decompressing the varices, thereby reducing its bleeding. I hope my short talk on upper GI bleed may be of help to you to understand the topic better. Till I meet again in another session, thank you.